Hello. In today's podcast, I want to just say a few words about a recent personal view paper that we had published in Lancet Psychiatry there in the last couple of weeks. Really, I want to say two things in particular. One about the process and underpin the paper, and secondly then about the paper itself. Yes, it was a really interesting process of writing the paper. Oftentimes, um, one person leads in terms of the writing, and then others contribute to drafts and edits and so on, or people divide up different sections of a paper. But what was really interesting here was that we met and had discussions, and it really was a genuine collaboration. So it was a collaboration between clinicians and people in health improvement and recovery, and myself as an academic. And what was really interesting was that where we started off in terms of our discussions was some way away from where we ended up. And it was led by Michael Smith, who is Associate Lead Medical Director for Mental Health Services in Greater Glasgow and Clyde. And he really pushed it forward. He also has an interest in suicide prevention. He chairs the Suicide Prevention Planning Group for Glasgow. So really it started off as, in the essence, as a paper around suicide prevention. And this is really the issue. The issues that arose during our discussions are really where we ended up in terms of the paper. And albeit we don't have all the answers, needless to say, we hope we have raised a number of key issues which really would benefit from much more discussion and, more importantly, much more action. So what we tried to do in the paper was really, as I say, raise that issue and highlight what we thought were really the potential maladaptive responses of health systems when faced with people who are suicidal or who are self-harming, and how we best respond to that challenge as academics and clinicians primarily, but the paper really is looking at the clinical response. And the argument in the paper is that because of the nature of the presentation, the nature of the individuals presenting, the nature of the health system, these things come together and lead to perhaps a maladaptive response, and what we talk about as a sort of dysregulated response. And we think this dysregulation really comes from a number of different areas, a number of different contributory factors. Now, there are many factors. We focused in the brief paper on three, and we reckon that the dysregulation is much more likely to occur, this dysregulatory response, which is characterized perhaps by negative feelings towards patients, perhaps an inappropriately narrow focus on diagnosis and risk assessment, and thirdly on perhaps abrupt and inconsistent decision making. And these characteristics of this sort of dysregulated response or dysregulated system, we think there are a number of contributory factors to that response or that type of response. The first is we believe is there's an issue around the ambiguity of the sick role of individuals who present following a suicide attempt or self-harm. Secondly, the health system, people who are working within the health system feel a need to respond, obviously, to such cases. And this and it sometimes is not clear what one should do, and I think that's a challenge. And then the third factor, which we argue comes together in this sort of tripartite sort of Venn diagram interaction, is that the other thing which leads or contributes to this regulatory response is that the potential for fatal outcomes. And so what we argue in the paper is that what's important to do in terms of a systems response is that if we're going to work better, or individuals are going to work better within these dysregulatory zones or this dysregulatory system, it's really important, first of all, that one acknowledges the risk of dysregulation. I think that's the first step, we argue. And that if we're aware of that, then obviously steps can be taken if we recognize that this is something which may, or is an increased likelihood of occurring. And then the second response, we believe, is that it's important to use diagnoses and risk assessment for guidance and not simply as gateways to help. And then the third one is we should use a relational response when working with patients or individuals. We should, and obviously such a response will lead to a more effective therapeutic relationship. So that's it. That was just a brief overview of what's contained in the personal view paper. As the full details are available at Lancet Psychiatry, and the paper is free for download. And hopefully it'll stimulate some discussion and perhaps some suggestions for how we may move forward in this really critical area when working with people who are suicidal or who self-harm.